2014 and coordinates and implements various VBP projects and strategies for the Healthcare Authority, including the VBP roadmap and the survey. He also led the implementation of the multi-payer virtual ACO payment model project under the State Innovation Model Grant. So thank you both for being here. I watched the emails that continued to go on over the weekend. So I really appreciate the time you put into this presentation. I also wanted to let you know that we have John Doyle in the audience, and John was North Central Washington's representative on the VBP action team.
All right. Well, thank you very much for the introduction.
Make sure your mic's on so anyone on the phone can hear you. Press the button in the front center.
There we go. The one that says push.
Yes.
They make it hard.
Well, thank you for having us here. It's our pleasure to be here. And today is actually my first day as the VBP manager, and I'm starting off by mismanaging the title slide here and ignoring Rachel's portion of the deck. So we're here today to talk about the VBP survey results as it pertains to North Central, and also Rachel's going to speak on some of the rural multi-payer transformation work at the end. So I welcome your questions throughout this talk. We did field a number of questions via email over the last few weeks, and so I'm going to do my best to speak to those. So apologies if I look down to my notes over time. I want to make sure I hit each of those as we go. And without anything else, we'll get started. So I want to provide a little bit of background about our role as a purchaser and our VBP strategies. A little bit about the Healthcare Authority and what we do. I'm sure many of you are familiar, but I want to make sure we go through this. We are, in fact, the state's largest purchaser of healthcare. We purchase both the Medicaid program and the benefits for public employees. And beginning in 2020, that'll include school employees as well. So right now we spend over $12 billion across those programs. And once we implement the School Employee Benefits Board program, that'll be actually closer to $14 billion. So it just gives you a sense of the leverage we have as a purchaser. And we're doing our best to use that leverage to drive health systems transformation by emphasizing incentives in healthcare. We want to reward patient-centered, high-value care, reward the performance of our contracted health plans and provider systems, and do our best to drive standardization and evidence-based care. We've set some ambitious purchasing goals, and by 2021, we aim to drive 90% of our state-financed healthcare payments into value-based arrangements across both Medicaid and public and school employee benefits programs. We intend that the statewide healthcare payment trend will be below the national average, or below the national trend. And we've had a number of tools in our belt to drive that change and attain those goals. We just wrapped up a 4-year, $65 million state innovation model test grant. We are in the middle of a 5-year 1115 waiver for Medicaid transformation. And we are driven by some legislative mandates to change the way we purchase healthcare. Our ultimate goal is to really bring about a healthier Washington. Consistent with the quadruple aim, we want to emphasize better care, lower costs, more affordable care, better patient experience, and better provider experience. We can't have one without the others. We want to get there by aligning our purchasing philosophy across our state finance programs. This means leveraging similar quality measure sets, similar quality improvement models. We're doing that across a number of our contracts. One of the questions we received ahead of this was, what if contracting negotiations cause VBP to go backwards? It's a very good question and a very big challenge when it comes to changing the way we do business and addressing the status quo of traditional fee-for-service payment. It takes a lot of work to adjust to new payment models, and it takes a lot of learning along the way. We know that we don't have all the answers and that every payment model might not have its intended effect, but we are committed to learning and adapting as we move forward. We have deployed a number of test models, particularly through the State Innovation Model Test Grant, and we are learning from those and trying to improve those models that we carry forward. Some of the key work that we're doing that we think will support providers and our contracted health plans in making them transition is emphasizing areas that can be aligned across programs and across contracts. So emphasizing the quality statewide common measure set. We have 5 quality measures that we are implementing in all of our VBP contracts, and we've deployed the same quality improvement model across our ACO model on the public employees side and the MCO contracts. So those are a few examples of how we try to alleviate some of that challenge. And I know there are myriad other challenges to consider, but those are a few things that we're doing. We try to be as transparent as possible as we move forward towards our goal of 90% by 2021. To do that, we release an annual VBP roadmap that captures some of the things we've done in the past and highlights some of the activities we intend to do in the future. It highlights some of the areas we're trying to align our programs. Another question we got is, one of our guiding principles is to reward delivery of person and family-centered care. So what does that look like in practice, and how is HCA rewarding this? So a lot of that comes to the quality measures we select and that we choose to hold providers and our health plans accountable to. We're trying to select measures that best correspond to whole person care. So choosing an appropriate mixture of physical and behavioral health measures that get to that. So some examples are antidepressant medication management across our contracts and diabetes management. There are a number of quality measures in our contracts that get to both of those. We also pay for 50% or around there of the births in the state. So we have a lot of influence to impact or at least pay for some early child care and maternal health care. So we're doing our best to implement evidence-based strategies there that address both physical and behavioral health needs of moms and babies. We're working with the BRE collaborative to come up with some evidence-based recommendations around maternal and child health care and how we can translate those into some payment models or a payment model. We're pursuing the integrated care for kids model opportunity through the federal government. And we're testing through the Medicaid transformation how we can use flexible arrangements in Medicaid to fund things like supportive housing and supportive employment. This slide is just to indicate one of the aspects of alignment and definition we're striving towards when we talk about VBP. A few years ago, the federal government, through the Healthcare Payment and Learning Action Network, put out an alternative payment model framework that defines and describes different payment models ranging from fee-for-service all the way to full capitation and population-based payment. We're using this framework not only to align with the broader movement that's happening across the nation, but also to give some specific definition to our goals. We've selected that blue box, categories 2C through 4B, to qualify as our VBP standard for our contracting. This is important because every model within that subset of this broader framework ties payments in one way or another to quality performance. And I don't know if you can see this on the screen, probably better on this one. Wanted to add a slide or two that go into some detail about the VBP components in the MCO contracts and in the Medicaid transformation. So right now we withhold 1.5% from the capitation payment made to each MCO. They can earn that back in 3 different ways. One, by demonstrating quality improvement on the quality measures in their contracts. And then that constitutes 75% of the earn back. The other 25% can be earned split between adopting VBP arrangements with contracted providers and then the intensity of the incentives in those contracts. So 12.5% for moving the needle on VBP in general, and 12.5% for actually the degree of the incentives in those contracts. So we think of it as a VBP attainment and a VBP intensity. That's how we kind of term those internally. On the Medicaid transformation side, we have a statewide accountability for VBP attainment. This is accountability to the federal government. This mirrors our purchasing goals. So by 2021, after demonstration year 5, we need to be at 90% VBP to earn our entire payments from the federal government, as well as achieve our own goals. And then the district VBP incentives also mirror our year-to-year VBP goals, and also include a subset of that framework. So if you look back at this framework, there's a subset that goes even further to the right from 3A and above to earn back the full, or to earn the full amount of the VBP incentives. Any questions before we jump into the survey on the background?
So the state has incentives, and then they turn around and provide incentives to the NCO.
Yes. Although the state
What was
incentive.
the question?
You want to repeat it?
Yeah, so the question was, in general, is it that the state has incentives for VBP, and then we turn around and apply those incentives to the MCOs? And the answer is yes, with a caveat. So the incentives to the state from the federal government pertain only to the Medicaid transformation, whereas the incentives we're applying to the MCOs are broader. So they are partially under the Medicaid transformation, but they are also just general to their contracts.
So and then can you go a little bit on the intensity part of it? I think you
Yeah.
mentioned it. What do you kind of...
So for an example, so the question was, explain a little bit the VBP adoption portion of the MCO accountability piece and the VBP intensity piece. So for the VBP adoption piece, that's saying MCOA reports to be in 55% VBP arrangements. That means 55% of all their payments to providers are tied to a quality contract in some way. So that's, say, 55% are in a shared savings arrangement across the state. What we're getting at with the intensity is, what's the actual amount of dollars within that contract that can be earned as a part of that incentive? So you might have a shared savings arrangement with that many providers, but within that contract, it could be a range. It could be shared savings of the maximum earn back of only 3%, or it could be greater. So we're looking at that, what those dollar amounts that providers can actually earn, or in contrast, would need to pay back or would have funds withheld. What are those dollar amounts? That's the intensity. Does that make sense?
Why was it full risk? Because that's like the ultimate goal.
Not necessarily.
Repeat the question.
Okay, thank you. So the question was, if a provider is at full risk, is that the ultimate goal? Not necessarily. We understand that providers are not all in the same boat. They don't have the same capacity or the same resources or the same populations against which to take full risk. So for some providers that makes sense, yes, that would be the goal, but for some providers that may not make sense, and we want to make sure that we're driving value-based arrangements in areas and ways that make sense for the providers participating.
Did we get this presentation as an attachment? Okay, I can't find it, but maybe Thursday.
We got some hard copies around too.
Well, I've got the hard.
Okay, good.
I want to be able to share with my team.
Got it.
JD, can I ask for the percentage for the managed care organizations they need to obtain? Is that statewide, or is that the percentage they need to obtain region by region? And I just say that because we're a very rural region, and so it would be easy for MCOs to hit Seattle and focus on those providers and forget about us. No offense, MCOs.
So the question was, I think there's a microphone over there, but the question was, how does the incentives with the managed care organizations, how does that play out on a statewide versus a regional basis? So for the contracts with the MCOs for their 1.5% withhold, that's on a statewide basis. For the incentives under the transformation, those are regional. So it's a both and proposition. So for their general contract with the state, for the MCOs, their 1.5% withhold can be earned back on the statewide performance. But they are also required under the transformation to attain regional targets. to achieve these. And there's, so, Yeah.
Are there goal percents that we put the MCOs to how much percent that is put onto the providers of that value-based?
yes, so similar to the VBP attainment, that's the left-hand table. In the middle table, that's the degree of incentives that we're driving. So it started out at 0.75% of total dollars paid out should be in the form of incentives. That was in 2017. Right now, for calendar year 2019, it's 1%. And there's a good chance that it holds at 1%, but that's a year-to-year change.
So the BBP share, how like that, we're saying that they have to have 30% in 2C, that chart that was up earlier. So that means they could be, that's fine if they had a global risk arrangement, that's fine. It's as good as if it was just a shared savings arrangement. So there is a lot of flexibility on where what that BBP arrangement could be.
So this is a target, but it could be more, it could be higher if the provider was willing to accept that higher level of risk, right?
Absolutely.
So I have a question. Tell me if I'm just jumping the gun. I should wait. But one of the challenges for an ACH is that there's HCA issuing contracts to the MCOs, MCOs entering into private business contracts with providers, and those are not at all transparent. Those of us trying to improve whole person care on a regional basis. So there's a sort of black hole there. Is HCA party to all those contracts? Because otherwise, how would you know if a contract with a provider is actually incentive-based or not?
It's a great question. So the question was, how does HCA know what the contracts MCOs have with providers look like, and how can we verify that they're hitting these targets? The answer is we are not privy to the contract details with each MCO and their providers. So to validate their numbers each year, we contract a third-party independent assessor, and we have an arrangement where the MCOs, that third party and HCA come up with a sampling methodology to which we can transfer a list of providers that each MCO contracts with that through the methodology guarantees that those providers make up a certain amount of their revenue or payments. And then from those providers, the MCO provides the third party assessor with a sample of the contract that outlines the risk arrangement and the total, the percentages in each of those buckets. That third-party assessor then says, yes, if the MCO reported this contract as a 2C, independent evaluator says, yes, we validate that this is in fact 2C, and they do that for all the 30 samples or so, and then they'll report back to us and say, with confidence, we can say this MCO reported correctly, and so we move forward with that. There is a write-back period when they're with that. So the independent evaluator writes back to the MCO and says, we see a discrepancy here, give us some more information, or this actually looks more like a 3A or a 2B. So there is a write-back, and so there is a process to make sure we're clear. But HCA is not doing the validation.
Thank you.
So moving on to the VBP survey. So we issue this survey every year to health plans and providers. This helps us track our progress towards our purchasing goals, but also to inform our current and future strategies towards health systems transformation. One question we got was, what value does HCA take from the partnering provider survey, and what actionable steps have been taken since the first survey was completed? So this last survey that we did in 2018 was the third iteration of this survey. The survey has changed quite a bit over time as we learn just about doing the survey and what's useful information to seek. So that's one thing we're learning, is better questions to ask. The value proposition is a little different when you look at the payer survey versus the provider survey. Payer survey is more about tracking our goals because we do get a sense of statewide payments. Provider survey doesn't give us as clear a picture on the VBP payment side because it's no guarantee that we're going to get close to 100% response rate from every provider across the state. So the provider survey is more an emphasis on the qualitative side of things. So what are the barriers folks are experiencing? What are some of the key challenges? What aspects are facilitating providers take on risk and engage in VBP? So it helps us identify trends in how folks are experiencing those barriers over time, if the same barriers are cropping up, if we're seeing things change over time. Some of the things we've done in response to the results are efforts to align quality measures is a big thing. Year in, year out, one of the key enablers we hear from providers is that aligned quality measures and contract incentives are always the highest rated enabler. So we're doing our best to align our contracts along quality measures and encouraging other payers to do so. This way we work very hard on the statewide common measure set. We know the data is a big barrier and we don't have a magic bullet, unfortunately, but we are trying to ascertain some solid technical assistance resources. And we're also working to continually build out and implement this clinical data repository. So an overview of the surveys. As I said, we issue it to statewide health plans across the state and providers. We developed the survey particularly on the provider side to be completed by administrators, hopefully to alleviate some provider burden. We know that a lot is asked of providers. They're getting surveyed all the time. They're undergoing a lot of assessments. So we want to make this as useful to them and as pain-free or as possible. So first, some data on the health plan survey. All 5 MCOs respond through their contract requirements, so we don't have to issue the survey informally anymore. It's a part of their contract. We did have 7 commercial or Medicare plans respond last year. And those plans are noted with an asterisk, are those plans that HCA has a contractual relationship in one form or another. So just another illustration of our influence as a purchaser. This next slide is a list of all the providers that responded. I'm not going to list them off, name them off here, but they're in the slide deck you can review. And now we'll look into some quantitative results. So this is across Medicaid, Medicare, and commercial lines of business. You can see these graphs are based on that APM framework. Moving from the bottom left corner bubble is a fee-for-service bubble, and the top right green bubble is the 4A and 4B, or population-based payment bucket. You can see that in Medicaid, we had about $2.3 billion in VBP, which amounts to just under 50% of total payments. In Medicare, that was right around 64%, and for commercial plans, it was right around 56%. So the thing to highlight here is for Medicaid, our target for this performance year, which was calendar year 2017, the target was 30% VBP. So we are exceeding annual targets, which is good. Of course, as we get closer to 90%, it's going to be more and more challenging to get those last few miles.
Excuse me.
Yes.
Over time, will you be weighting the 4A and 4B more than the 2A and 2B? I mean, theoretically, you could have 90% in 2A and 2B, but I think you want to be further along that continuum, right?
So we have begun building out some subsets into some VBP contracts. We've done that on the public employee side, and we've also done it under the transformation and some of the district incentives. Right now, that's not part of the MCO contracts, but we are exploring ways to kind of pull out a chunk of the VBP incentive piece and make it more aggressive towards the 3A and above floor to get more of that total cost of care consideration. Right now, that's not in the MCO contracts for as a part of the withhold. It's part of the incentives under the transformation, which are in the MCO contracts, but it's not tied to the withhold. One question we received is, what does it mean for an organization if both Medicaid, Medicare, and commercial plans are in similar VBP arrangements, say a 3B two-side risk arrangement? How similar are those arrangements? So HCA doesn't know exactly or have a way to ascertain how similar those arrangements are, other than a high-level construct that they're in the same subcategory. But it's likely a positive thing for participating providers in that they're getting faced with similar expectations around shared savings. Hopefully quality measures are aligned. We're confident that that's happening on the Medicaid side. Unsure how that aligns with the commercial side. But that is part of the black box here for the state, is that we don't get a clear picture of the finer details of all the contracts to compare and contrast. So when you look at the statewide results from the MCO VBP survey, you can see broken down by region. North Central is outpacing the other regions by quite a considerable margin. This region is at 62%, and the next closest is at 56%. So that's definitely a positive.
You know when that data was?
This was so the performance data was calendar years 2017.
Doesn't really change though, because we still have, even though we changed our model, we still have value-based performance. Yeah.
So we got a question about confluence, and I think there was a little confusion on our end about what that question meant. But let's just take this as an example. So Confluence is a large provider in the region. They represent about 30% of all MCO payments in the region. So any substantial changes in their contracting, one way or the other, is going to have a pretty significant impact on regional performance in terms of VBP attainment. So I just want to call that out. If hypothetically Confluence reverted all to fee-for-service, that would have an impact of bringing down the regional VBP percentage to about 48%. But if they continue to hold value-based arrangements, it's going to have a positive impact.
So I'm sorry, I'm not speaking for Confluence, because those people who can affect this are here in the room, but it sounds like what I just heard was that they're going back towards fee for service, but there's still a value-based component to it. So it seems like it would stay at 62%. Is that?
If the value-based component qualifies as a 2C or greater, then yes, it would have no downturn effect.
So just to make sure we understand that, so the going to fee for service is about how Confluence gets paid by the MCO. The value-based payment rating is based mainly on how the providers get paid by Confluence, right? Their pay has to depend in part on achievement of metrics or not.
No.
Confluence.
Yeah, so it would.
So it's whether Confluence is being paid on the basis of, so in the fee for service arrangement, there would have to be something about a percentage. It has to be achieved by hitting a performance target of some type.
Correct. So
even though it's not capitated.
Yeah. So let's take category 2C. So it's a pay for performance model. So if Confluence was in a foundational fee-for-service arrangement with their contracted health plans, but they had a rate increase possibility for the next year, if that rate increase was tied to quality performance in some way, like say they're guaranteed a 3% rate increase, but it could go up to 4.5%, 5%, whatever, based on quality performance, that would qualify as a 2C, which would still qualify as VBP under the contract, so it wouldn't bring that total VBP arrangement any lower. So some specifics on the provider survey, particularly as it relates to North Central. So I've got some slides that break down the statewide results and compare it to the regional results. The numbers on the graphs are a little small, but the general gist is for respondent organization type, it's pretty similar in this region to the statewide trend. Almost half of the providers in this region were behavioral health providers in some form or fashion, and a good number of rural hospitals or clinics, and mostly not-for-profit. Some of the quantitative data. So this is some Pareto charts on just the size of the provider organizations. So for the statewide, the most common sizes were 6 to 20 or 100 to 500. These are for employed clinicians. And in North Central, it's from 6 to 50. Actually, 16 of the 23 responding provider organizations were in that 6 to 50 employed clinicians range. So fairly similar. Most are still in the 6 to 20 range, but a little bit different on that second tier. When you look at the total revenue reported by providers in this region, Medicaid was about 170 million, Medicare 360 million, commercial 380. I want to caveat this slide pretty heavily, especially if you look back to the statewide results. These revenue results are provider organization wide, regardless if they're in multiple regions. So for providers in 2 different regions and they have a total revenue of 100 billion or 100 million, the way the survey works, that 100 million is going to show up in both regions. So it's not a fine science when we ask this question. It's just a general question. One of the questions we received is, why is North Central revenue so low? When we compare North Central to the other regions on the provider survey results, the revenue was quite a bit lower than the other regions. Part of that is because of that caveat. There seem to be a lot of providers that are only in North Central, or if they're in multiple regions, they're fairly small providers. Whereas in some other regions, there were providers that were in multiple ACHs, and so that combined revenue kind of had a disproportionate effect. But when you compare the regional payments based on MCO payments, North Central is still in the lower half of the regions in terms of total MCO payments. It's about 236 million. I think there's 2 other regions in the low 200s and 1 below 100. The average is, I think, right around 400 or 500 million. Any additional questions on that?
Do we look similar to other rural regions in terms of, I don't know, Medicaid looks to be about 20%. Is that higher or lower? You know, Medicare as a percent of total, is that higher or lower?
The Medicare percent is pretty consistent. It's when you get to comparing Medicaid and commercial, that's where the bars get a little variable.
I'm assuming our Medicaid is a higher percentage of our total than, say, other places. Is that correct?
Yeah, I don't have I haven't parsed out the data to look at it, but in general,
okay.
Yeah.
So let me add something, Dave. As you know, there's 4 of the ACHs are considered rural, and Olympic and North Central are the most rural. North Central has the smallest population. We have just 1 tribal entity in North Central, whereas in Olympic they have more than 1.
Some of the qualitative data. So if you look at, we ask a question, in general, how would you rate your experience with VBP? You can see from this, both statewide and regionally, there's a lot of not applicable. So a lot of providers either have very little or none experience to date in VBP. In general, those folks that have had experience are either neutral or positive. It's pretty small numbers in North Central for this question, so it's tough to to say what the trend is. But why so many not applicables when VBP is such a hot topic and we hear about it a lot? What should providers be prepared for? I mean, the hard and fast answer is that the state's continuing to move, the MCOs are continuing to move. So a lot of these NAs are going to need to go to the experience column. So the biggest things are identifying how to support providers taking those first steps. What are the things they need to learn about contracting wise, billing wise? What are the care transformation changes they need to make? Those kind of questions. Again, not a magic bullet. Every provider is different. So we're doing some work that I'll get to a little bit further on to try to tease out some of those details. So the question was there any feedback as to why the negative, why some of the bad experience, very negative or somewhat negative experience? There was a text box for explanation, but I didn't pull out any trends, at least for this region. But that's something we can follow up on.
Do the providers have any input on that? If you're in the room.
I think it's a pretty broad question because you can see that, goes from two, the types of risk and value based is totally different that everybody's experiencing. So to ask one, right?
Sorry, I think it's a pretty broad question to answer because it's, there's a whole bunch of different types of value-based care involved there. So some people may be answering at one level versus another level as they're responding. So
I think another issue might have been that each MCO has a little different set of incentives. Some are related to, the state has mandated, okay, you all have to have this, but everybody does it a little bit different. And so we're having to do 3 separate things. And if everybody had the exact same requirements or quality metrics or something, that might make it a little easier.
So, and that leads us right into the next question. So, what are the enablers and barriers? So, getting to that point, the most common cited enabler is both statewide and regional. Regionally are the aligned quality measures and definitions in contracts. So for North Central, that was tied with common clinical protocols and guidelines, which was actually unique to this region. I mean, we're dealing with small numbers here, but that was not one of the top noted enablers statewide. The barriers, I'm sure no surprise to the folks in the room, lack of interoperable data systems consistently rises to the top. One of the things that rose to the top in North Central that was unique, at least in terms of the top barriers, is the insufficient patient volume by payer to take on clinical risk. So these are some of the things we have to consider when we talk about that framework from 2C to 4B. So some providers, they just may never have the patient population to be in a full risk arrangement, and that's okay. But there are still ways they can engage in value-based care and in value-based payment arrangements. Another barrier is lack of timely cost data to assist with financial management. That barrier was also tied with lack of consumer engagement. So these are some of the things we try to take back, and when we have efforts around technical support or technical assistance, we try to come back to the survey and see how we can deploy resources that get to some of these barriers. And the interoperability is probably, it's no surprise that it's at the top because it is an extreme challenge. We're working hard to advance this clinical data repository, and we hope that that will add value over time. But I know that there's a lot of other challenges regarding data as well.
Excuse me, do you know if people are talking about one provider's system talking to another provider system, or is it the provider system not being able to talk with the MCOs?
So the question doesn't get to that, but I would say it's a both question. Not knowing the clinical care that your patient has gotten if they received care outside your clinic walls, but then also getting disparate reports from health plans on different frequencies or in different formats is also a challenge. So some anecdotal things we've heard over time. The question in the survey doesn't get to that level of specificity. So I asked a question about experience relative to noted barriers over the last year. Most folks haven't experienced an improved situation or a worsening situation, but it's about split for those that have experienced had change in experience in this region. Statewide, more folks said situation improved than worsened, but again, small numbers on the regional side. We, in the 2018 survey, we added a couple questions around health equity. This was a new question to that survey, so you know, this is one that might change over time when we'll certainly learn more over time. But the trend is more providers are collecting race, ethnicity, and language data, and far more are collecting it than are assessing performance based on that data. And there's a lot of reasons to this. It's challenging. It's a challenge to collect. Its reliability is not always guaranteed. So there's a lot of things we need to do around improving the quality and the robustness of collecting this type of data before we can expect there to be, you know, real performance metrics based on it. But it's a direction we're committed to moving. When we talk about integration, we asked a question based on the SAMHSA 6 levels of collaboration and integration. Both statewide and regionally, most provider organizations are at level 2, which is basic collaboration between physical and behavioral health providers at a distance. Fairly even spread on the upper levels. But the encouraging thing is that statewide, 70 responding providers intend to move to a higher level over the next year. And in North Central, 18 providers expect to move to a higher level this year. Asked 2 questions around technical support. What type of technical support have providers received? And then the next question is what would be the most helpful moving forward? The big takeaway is providers are receiving a lot of technical support, both or through value-based reimbursement, behavioral health and physical health integration, and practice transformation. If this was a Venn diagram, there's a lot of overlap between those 3, so maybe not surprising. And then not surprising either that providers still want these 3 types of technical support. So, and I think it's important to consider the overlap between them. You know, practice transformation is essential for engaging in value-based reimbursement models and is a core component to behavioral health integration. This is just about future plans for VBP. Asked, do you plan to increase your participation in VBP and by how much? In North Central, 11 of the responding providers said they plan to increase by at least 10%. The proportions are fairly similar to the statewide results. So that's encouraging. And only 2 providers in the region indicate that they plan to decrease their participation in VBP. So overall, statewide and regionally, we're seeing an overwhelming trend towards increasing. That's good, but we want to make sure, you know, we're not leaving folks behind as well. So circling back on some of the technical support, we know that this is a huge need. This is a big desire for providers and the state in general. We have some resources through the transformation to work with MANAT around a value-based purchasing toolkit or compendium of resources. Right now they are conducting informational interviews with ACHs, providers, and health plans. They have a draft toolkit, which is just a compilation of a variety of resources getting at those 3 things with a focus on VBP. And we're trying to ascertain what's the most useful from those resources, and not only what's useful, but what are the most useful means of engaging with those resources. So who's the best to deploy them and interface with providers in walking through them? Would they be sufficient as web-based tools, or do they really need to be in-person implementation aspects? So we're trying to ascertain some of that information and better formulate that toolkit. We have limited resources when it comes to funding in-person practice transformation. We were fortunate through the SIM grant to build out the practice transformation support hub and fund a lot of practice transformation through Qualys. We still value that and believe in that work and want to see it continue. And we're continuing to look for opportunities to provide resources for that, but we're also trying to figure out if there are better ways to resource some of that technical assistance. So whether that's through ACHs or whether that's through the health plans themselves, or if it's providers coming together to coalesce around some of these tools. But we have a lot of learning to do in that regard, but we at least have a lot of resources to kind of pull and learn from other states and other regions that have done a lot of good work in the practice transformation and technical support world. Another thing I want to highlight is the more and more we get into this conversation, there's more, or it's a more apparent need to have better role clarity when it comes to the state ACHs, providers, and MCOs. Who's responsible for what and when? So we don't have, we don't have the final book on that, but it's a conversation we've been having, particularly mostly over the last 6 or 9 months. That's something we want to continue to further define, and hopefully with in partnership with Accountable Communities of Health, we can get to a place where all parties involved had a better sense of whose role is what. So in summary, health plans continue to increase their adoption, and we're outpacing the annual targets under the contracts and the Medicaid transformation goals. Provider experience with VBP has generally been positive for the folks that have engaged, although there's a lot of ground to cover there to get more folks involved. Providers generally plan to increase their participation in VBP. One interesting difference between the provider and payer survey is that health plans report a lot more VBP adoption than providers. I think part of that is just when you look at denominators, we capture most of the health plans and probably 90% of all the payments in the state, whereas on the providers, we have no sense of what the denominator actually is, and we're confident that we're not close to a full statistical model there. Lack of interoperable data systems is still the top barrier, and we recognize that. But we do have some tools and some ideas to help facilitate the acceleration towards VBP. So one of the questions, well, I kind of already answered this, but how are we handling the mixed responses between MCOs and providers? One of the things we're doing to try to increase the participation of providers is better utilize professional associations and things like the Transforming Clinical Practice Initiative. We've got some buy-in from folks that are involved in those to disseminate the survey to their members. The MVP Action Team has been huge, as have the ACHs in the last 2 years in promoting and disseminating the survey on the state's behalf. So we really appreciate that, and we'll continue to lean on our partners to build out the denominator in the provider survey. So that concludes my slides. Before I hand it off to Rachel, any questions on that portion of the presentation?
JD, I have a question. So is the MVP Action Team done now? They're no longer going to meet?
So the MVP Action Team still exists. We don't have plans to bring them together in person for the time being, but they're still a valuable group that we are engaging with virtually. We want to leverage their expertise where we can. So we're not disbanding the group, and are looking for ways to better utilize their time and to utilize their expertise efficiently. Any other questions?
Can I ask, Just as an ACH side, knowing that we saw a lot of providers still looking for additional technical support for value-based purchasing, that's a very broad statement. Can any of the providers or HCA share some thoughts on what do you guys think is needed for technical support to help providers move to value-based care or value-based contracting? Is there anyone who has any thoughts on that?
In general, there could be a cost savings to all if the reporting that was required was all uniform instead of one MCO requiring something in one format versus another format. So there's a lot of internal cost to develop these things and to go searching for these numbers. So.
Rick, do you think it'd be useful to have access to claims data better than we have now? You know, to be able to see if a patient we're taking care of in a primary care setting actually has been in another ER or a hospital somewhere that we didn't know about.
You know, definitely. We have some of that, Doug, but not all of it. So, I mean, we used to have more how we contracted, but not anymore.
So that's a really interesting question to bring that up. So the virtual ACO model that we tested through the SIM grant was essentially around that, using MCO assignment files to pull claims and encounter data and share that with participating providers. So we piloted that approach with Northwest Physicians Network and Summit Pacific Medical Center. The cost to the provider to do that is to have a system to aggregate that data and utilize it. As from the state's perspective, we think that's one of the tools that we have as the payer. We have access to all that data, and we think that we can use it to support providers engage in some of that care transformation and population health management. We realize there's a cost on the receiving end, but we are building out our internal capacity to pull and transmit that data where necessary or where appropriate. It takes agreements with the health plans and the providers to do so, but it's something that we're looking to build out in the future.
A challenge for us has been that the state has asked for, demanded, whatever you want to call it, data, but they have also said, we're not going to promise that it'll be kept safe or, you know, only appropriate people will see it. So it's at your own risk. We will not indemnify you, but we want you to send us the information. And so we're struggling with making sure we follow HIPAA and protect ourselves from inappropriate use, but the people who want it and are going to use it are not willing to, in effect, help us do that. That's a disconnect. I'm not blaming anybody. I think all parts of the state need to be on the same page.
When you say the state, are you referring to the healthcare authority or another agency?
Not necessarily.
You don't have to name them. I'm just curious.
No, not necessarily. I'm just saying the state wants to have us all contributing patient information, protected health information, but at the same time, the state, and I'm using that in the broadest terms, cannot or will not commit to the same things that we would ask another organization to sign, you know, for a business associates agreement. They promise to keep the data safe so that we don't get sued by a patient.
Yeah, and I think, you know, these are considerations and challenges that are going to continue to be at the forefront as we start talking about data and get more into sharing data. I can only speak from my perspective at the Healthcare Authority. I've done a considerable amount of work with our data teams and our privacy teams, and I know the Healthcare Authority takes privacy and security very seriously. I just went through our new data governance process, and I'm confident that at least from our perspective, we're doing our best to ensure that. And we also expect the folks that we're sharing data with to do the same. There's always things we can do better. There's another.
Just a comment that using claims data for quality measures has a lot of holes in it, especially when you're talking about a rural health clinic. We don't use the same codes for our care. We aren't able to capture a lot of those quality measures like smoking or, especially because we don't charge for those. We're at an all-inclusive rate, one code. And so what happens when I look at the all claims database, we look like crap, but that's because it's not capturing the data that we're actually having, like EMR for these patients.
So let me rephrase this, and you can correct me if I get it wrong. So one of the challenges, particularly for smaller rural clinics, is they capture, or the data they capture doesn't necessarily align with that's being reported in the all-payer claims database and claims systems from other provider groups. So when you do a compare and contrast, things look a little different. Rural clinics may look a little bit worse simply because the data is captured differently, not because care is given differently.
It's not captured at all because it's a one fits all size code. It can't, you put everything into one code. You'd have to code for things that you don't bill for.
So there's some coding challenges the way rural clinics code versus other.
And even if you submit the code as $0, it gets eliminated in the process because it's $0. It just takes off. There's no way of transmitting that data claims data.
Is there another question or comment?
Just thinking out loud, and maybe people disagree, but I think almost in a way you may have set the bar too low, and it's understandable because you're dealing with a wide spectrum of different types of provider groups, and MCOs probably have a different relationship with a smaller group who can't afford to upscale and hire case managers, for example, as opposed to a larger group that maybe wants to do that, but looks at some of these like category 2 C and D and says, well, really the upside isn't enough to pay the salary of a case manager. So it's unlikely it's going that this level of value-based arrangement is really going to innovate that much. Whereas, probably there's more to be gained pushing up into category 4, right? But I'm not sure how you move that. I guess I'm wondering what's past 2021. For those of us who are eager and see the promise in this, I think part of my lack of enthusiasm is just that we're just not there yet. We're just not realizing the possibilities here yet.
Yeah, I think it's sort of a double-edged sword proposition because yes, the potential benefits increase as you take on more risk, as you get closer to those population-based risk arrangements. But how do you go from 0 to that overnight? It's really challenging. So it's a good question, a good point, something we all have to wrestle with.
So going back to the topic of kind of role definition, the state being the entity, HCA, with all the data on the Medicaid population and other populations, again, the more secure in the state or payer. What kind of dialogues are you having with the MCOs on an ongoing basis about trends you see, areas of focus that really should be addressed, or do you just kind of leave that up to the MCOs since they're taking financial responsibility, for the Medicaid population?
So the question is, with the state's role as the purchaser and the contracting entity with the managed care organizations, with our access to their data, how are we working with them around trends that we're observing and working with them on targeted improvements? So when it comes to VBP, our focus is really around what's in the contract tied to the withhold, so VBP attainment, density, and the quality measures. So quality measures we put in there are the ones that we think are important to address and emphasize right now. That being said, those have a very large team that works directly with the plans and works with them on a whole slew of other initiatives and improvement projects. So there's a lot that goes on beyond the VBP components of the MCO contracts. I can't speak with the expertise to that, But I know there's a lot that goes into it.
I'd just add, no, don't want to go look at it, but all the contracts are online, the MCO contracts. But we do have various meetings individually with MCOs. Is collectively, in December, we convened all the MCOs around behavioral health. What are they doing in terms of behavioral health and physical integration? Trying to think, would that be a multi-payer opportunity? But I would say, yeah, Medicaid, in policy, participates in some of the meetings, but there's multiple meetings happening at multiple levels of the agency. So the CEOs meet 4 times a year with our Medicaid director. Our policy teams work with the policy folks at the MCOs. That's what
I think how that then gets translated to the provider community is potentially what's lacking. What are we doing well in North Central Washington as far as taking care of a population? How do we compare to other areas? Where do we have opportunity? And I think that's where, again, this role definition and aligning the quality measures, making sure that data flows from the state through the MCOs to the providers is important. We find that with a lot of payers. Tell us where we're doing well, but tell us where we need help.
So are these forums places as well that you could have those discussions at the local ACH? I think that's one area that I think we did create the MVP action team to have some of those discussions. And as JD said, that, it's a little hiatus right now, but I would think that some of the ACHs could have those discussions, but we're happy to participate in those discussions as well.
Only if we have the data, and all the data we got are 2 years old, and they're not really framed in the way that that he's talking about. So I think that, it seems like we come back to data so often, but that's the problem. The state hasn't accepted the role of using the tremendous power it has by being the biggest payer in the state to feed back to providers what could be done to improve it. That's what Mr. Doyle is saying, and I think we've all had that frustration, and you even see that in the demonstration funds flow analysis, where we're supposed to be getting revenue through 2023 based on what we do in a period ending in 2021 because of the 2-year lag. And
I guess I would just ask, the question that in the groups that could, or the size, it seems to me the state would want groups or large systems to move to a 4B. Take full risk, because then you're really doing that. But what's the state doing to work with the MCOs to put guardrails and policy around how you work with those members? Because it really comes down to negotiations, and then there's not trust, right? Because you're working with a payer, and you really don't know what the state's going to do. And so, just having stepped out of full cap after close to 30 years, it came down to those kind of problems. That it's like, really, you're going to take that much of a fee to do minimal work? So the state has to, if they want us to move to 4B on big systems, they can't just leave it to the MCOs to negotiate the rate at which they're going to do that.
Amen.
The state's got to put some guardrails around that.
And I just want to pull that together by saying that's a perfect example of how you have HCAs connected to the MCOs by contract. The MCOs are connected to provider organizations. That's not the same as a provider by contract. And then there's the black box. And if the state does not cause the MCOs to do some of these things we're talking about, no one will. And a general incentive to earn that 1.5% or whatever it may be will certainly cause them to put pressure on providers. But if providers are getting paid so little that they are losing money on the care, there's no value-based revenue, right? Now, some of their inadequate payments may be based on value criteria, but that's a little different. And how do you get an individual provider sitting there with a patient to do something different? That is the name of this game. But that is disconnected organizationally and contractually from the actual flow of money and the rules that go with it. And that's our problem in the demonstration in this state compared to some other states. There's a big black hole, right? It's not a black hole, it's jelly right in the middle of it. And the only operator in the position to fix that is HCA, but we don't see that happening.
This is Sheila. I have a comment.
Hi, Sheila.
So I disagree a little bit with the comment about the actual provider in the room being disconnected, because there are incentives. You know, if you can hit the cost incentives and then hit the quality incentives, I do think that there's a need on the organizational level to pass that savings in some way to medical teams. I'm being very specific on using medical teams, because to do any of this work, you can't just incentivize a provider. You've got to be able to incentivize that support staff that makes it happen. But I do agree that margin is so small that it does make it hard for provider organizations to figure out how to push some of that incentive down. Just as a different perspective, I do think that the MCOs are working hard to provide that data. So we've worked with, you know, 2 of the largest MCOs here at Moses Lake Community Health, and it has taken years in which to develop data between the MCO and the provider to make quality improvement. So it just is, it's a significant amount of time. Two MCOs have done good by us, but it is a really hard lift to get that data. And I don't know how you bridge the gap to take that data that is between the MCO and the provider or the organization and get it to a spot where it can be available statewide.
I just had a technical question, just real quick, to JD.
Go ahead, Courtney. And I know we need to move on to Rachel's part.
In regards to your data sharing comment, are you referring to the APCD, or is this like a new data sharing?
No, it's not the APCD. So
Okay.
This is, and I can provide some more information after the fact, but this is one of the test models under the SIM grant. It was based on the claims and encounter data we already have. And so it was we based the data that we would share on MCO assignment to the participating providers. And we would compare, you know, smarter people than I would take the assignment, query it to the claims encounter data, and then transmit that to the providers.
Thank you.
On a monthly basis.
We do have a second half or a second third of the presentation that you've come to give, and I don't want to.
And it actually kind of addresses, Doug, kind of like what's next and why, and so this addresses why we've been thinking about this. So a couple of things. I have been asked to talk on just a high level on a rural multi-payer transformational model. I can sense around the room, some folks probably are more familiar with this than others, but I'm happy to have follow-up conversations with anyone on more of the technical details. I want to stress that this is a moving target. We are working with Medicare. This is not the slides and the that I'm going to show today are proposed. It's not, we're not going to, I think some folks think, and that's, they're totally appropriate because we've been, we're in a little bit of a weird place with Medicare right now. We're not going to come out with a model tomorrow and ask everyone to join. I mean, this is, it's going to be probably at least another 4 or 5 months to when we solidify some, the technical components and we put it out for either public comment or we ask providers and payers to officially weigh in. So I want to just make that clear. We're not, this is not this is not, you know, at 99% finished. But I'm going to talk about this and then talk a little bit about how it fits in with our journey and specifically go back to what JD was saying about the BBP targets and because that's a big reason why we've picked the approach that we have done. And I'm also going to touch upon some of the other rural efforts that have been going on over the last couple of years, and I know Scott's been involved in Rosalinda under the RAP project. Rural transformation. Some of Doug's comments. You know, the healthcare authority. When we first started our state innovation model grant, we have an ACO for public employees, and we started with that because some of the urban areas are ready to do that kind of contract. And I would say that we now are going to the rural work is, I mean, we've always been interested in helping these providers because they are very different. You know, urban providers are very different from rural providers, and I know I don't even need to talk to you guys. Everyone knows that much more than I know. But even one rural provider is very different. So this, I would say, is we started this kind of rural journey for a lot of reasons. One is Medicare is very interested in playing and improving care in rural communities and sustaining access to care. It's also rural providers have been traditionally left out of some of the federal efforts. So this slide shows that every major stakeholder in this area has a different perspective, but the one thing that everyone agrees on, as we've been talking to folks around the state, is that we really need to sustain access to essential healthcare services in rural areas. And the healthcare authority, as a purchaser as well as a convener of care, feels very strongly about this because we're going to have a lot more school employees in these areas, and we want to make sure that they have access to essential health services. I'm not going to go through this, but these are some of this summarizes what we're hearing from different stakeholders and why they're interested in participating in a multi-payer transformational model. So this is old, okay. So this talks a little bit about our journey of where we've been, and I'm not going to go into this too much, but I want to acknowledge that from our state innovation model grant, and talked a little bit about model 4, and that's kind of, we have our own model 1, 2, 3 kind of internal speak for this, folks. But we started out with proposing an FQHC payment model 2 VBP arrangement, and part of that kind of phase 2 of that was also to move critical access hospitals to VBP arrangements. And so we've been on this journey a long time, but I know a lot of other folks have been in it a lot longer than we have, starting in 2014 with the Hospital Association and the Department of Health. And they worked on a pilot, or they created a report, and I did not participate in this, so I can't speak firsthand. But a collection of hospitals, the small, most remote critical access hospitals, came up with it was kind of an outshoot of this report of figuring out how do these critical access hospitals survive and prepare for value-based payment and purchasing arrangements of the future. That work the state supported. At the same time, and I'll show another timeline, we also had gotten some input from the federal government that they were interested in working on state-based models, but it had to be a broad accountability, meaning it had to be as we heard from them, and I know seems like a lot of folks have different, had talked to different people at the feds as well, but it had to be kind of in category 4 if they were going to play. If they were going to put a lot of resources and they really wanted to raise all boats, it couldn't just be a couple of hospitals. It had to be a statewide thing, or at least a very broad approach. So as the RAP work continued, the legislature passed a couple bills to help accelerate that RAP work, as well as we had this other I would say kind of parallel track going on about how do we work with Medicare as well. So I think it's important to point out that the RAP work, there's 2 pieces of legislation that's moving forward, that have moved forward, and one was for the healthcare authority to work with RAP on creating an alternative payment model. And the healthcare authority has been working with, has received Medicaid match for a total of $2.1 million over 2 years starting last year to help these RAP hospitals move to value-based payment. And I don't know if Scott or Rosalinda wants to talk more about the successes they've seen under that. Happy to let you. But I wanted to point that out because I know it comes up in conversation, and I also want to point out that we recognize that work, the healthcare authority recognizes that work, and we have been very direct with the federal government that whatever payment model we work on, there has to be considerations for these smaller hospitals to be part of a bigger budgeted population health beats model. And, you know, they hear us, and that is part of kind of our guardrails that we have put forward, in addition to this being a voluntary model for for payers to be part of, or for providers and payers to be part of. So I just wanted to talk the 1520 implementation, the $2.1 million going to these RAP hospitals. I've already said that we were able to draw down some Medicaid match funding, but the critical access hospitals are working on two. They're using the transitional funding for building capacity for behavioral health services and care coordination services, and linking quality performance to implementation of the behavioral health. So that we'd like to, it's our intent to build upon that work as we move forward for any of our rural model, as we continue to work with the federal government on them participating on a rural transformational model. So here's the timeline, and I'm not going to go into a lot more, but the kind of the upshot is we really support the work that the RAP hospitals are doing, and it's not lost on that they're very small and they're very different than other providers in terms of getting into this VBP space. So the rural transformation model, I know many of you have heard this presentation before. We back in last summer, we really ramped up work with our federal government to say, you know, we really want to work with you on a rural model. And the primary goal is to sustain access to care, essential care in these rural communities. But there are some secondary goals, and a little later in my presentation I'll show they really are along the lines of the triple aim, and line up with other transformational efforts that we've done since 2015. Improve health outcomes and quality care, incentivize rural health systems to provide services that meet the needs of their communities. We know that that's really hard to do now under the current payment system, and improve the financial state of these hospitals, and as well as reduce the growth of hospital expenditures across payers. The proposed approach that we put out in September is an alternative payment model that's a budget for all rural hospitals, and I'll talk about how we define a rural hospital in a couple slides. Also, and more importantly, I think, is, you know, the payment model has to really drive delivery system transformation. So some of the comments that I've heard today is, you know, we have an approach. We're thinking about the transformational strategy would be participating hospitals submit a care transformation plan, and we work with the MCOs on maybe some of these alignment opportunities, or, you know, how can we make sure, how can the state set a little bit more guardrails for the hospitals, as well as in terms of clinical strategies and evidence-based approaches for the payers as well as the providers. Again, why, I get a lot of questions, well, why are you taking this approach? For one, we do believe Medicare is critical to a successful payment model in the rural areas, given their high concentration. I was talking to a critical access hospital the other day, and it's, I think 80% of their revenue is Medicaid and Medicare. And I think even 50% or 60% was Medicare. We believe that this approach, while a couple states have done it, and those states are very different from us, would bring stability and predictability for these health systems, for them to sustain and preserve care in their areas while they start when they can think about new care models to invest in. And then we also see it as a opportunity to address other barriers, regulation barriers that come up between the Department of Health and us, workforce certification, regulatory areas. We work well with our sister agencies, but this could be another model for us to really link arms on thinking about, well, there's the Office of Rural Health there, we're the payer. How do we work better together to make sure that we're making provider lives easier? And I also will say, it is an opportunity, to your point, you know, we've been thinking, well, we're on this transformation journey, what's next? We've built out these ACHs, and we've built out a lot of other innovative structures and strategies, and we have ambitious VBP goals, but they're not it's not, we need something that's going to help sustain us and sustain the work of the ACHs. So we believe that this model, there will be a role and that will be addressed under this model. So as I mentioned, this is just to illustrate the different, the goals of the 3 transformational approaches or projects. You know, the SIM grant started in 14, then with the Medicaid transformation in 17, and then the proposed rural transformation model would be in 19 or 20 or 21. But really along the lines of achieving the triple aim, like how do we want to sustain access to care, we want to promote care coordination across different provider groups as in rural areas, and we want to reduce the growth of hospital expenditures. And those have been themes across all of our transformation projects since 2014, 2015. And then this is another way of looking just at the VBP and the transformational elements across all 3 projects. I want to point out the rural transformational model would be a 4B. So we have been thinking, well, how do we help, as JD talked about, there's VBP targets and attainment, or the DSRIP incentive funds for ACHs and MCOs ramp up. And this would help satisfy and help the MCOs as well as the ACOs hit those VBP targets. And those VBP targets are in the middle column. We also see it being, again, a key theme is that it builds upon what we built. We're not trying to build something else. We're not trying to head in a different direction, but how do we continue to build on a care transformation strategy? Maybe we re-up a toolkit of a direction for these providers to take. We also see it as our opportunity for a multi-payer forum. Our state that has not had a multi-payer forum, and we, as well as employers to participate, because they have a big interest in not just the rural areas, but just a general interest in affordability. And we work with other purchasers pretty closely. And most importantly, or I say as important, Medicare. They're very, very interested in this. We have done a lot of work under a state innovation model grant with them. Things have slowed down a little bit, but we have, our conversations have been very encouraging. And if you look online of any recent speeches by CMS, that they will be, they have committed to working with states on rural solutions. And we are hoping to be ready. We are ready to work with them as they move forward. And I want to call out, we still, as I mentioned, there's transformational core strategies across all these things, data. We have a lot to work on. And again, I think we see this as another way for us to continue to help providers participating in this model with direct data. All needs to be worked out, but we acknowledge that there are some gaps there. I'm not going to talk, I only have 5 minutes left, but just talks a little bit about the components of global budget and the fixed annual revenue versus the care transformation support. Heavy lift by those all involved, but there's the point of this slide is it's not just a payment model, there's a huge care transformation strategy as well that goes with it. In terms of eligible hospitals, we are taking a broad definition of rural. So any hospital that is in OFM, State Office of Financial Management, designated rural, designated county would be eligible to participate. And by that definition, there's 52 hospitals that fit under that definition. Yeah. Oh.
HHS says like 100 and some is rural. Is it kind of the same thing? 100 some beds.
I'm not sure. I actually don't know the crosswalk between the OFM rural designation. I don't think it's a bed. I think it's a population.
Okay. If you look at that APCO rate, every one of our hospitals is on there. Right. That's every hospital in North Central Washington. Rural.
And 5 of those hospitals in our region were part of the RAP group. So just points out how rural we are.
So as I mentioned, how we define rural hospital, and I'll talk a little bit, I might run out of time, but this is voluntary. It's voluntary for payers as well, but we have had a lot of, and with some folks in the room as well, have attended those payer meetings, have been very encouraging. And it's our expectation that our health plan partners for Medicaid as well as PEB and SEB participate in this model when we secure agreement from the feds. So we hope between that and other lines of books of business of these payers that the hospitals that do choose to participate would have a significant portion of their patient net revenue in this model, because it would be very hard to have only 40% of their revenue in this model and 60% in fee-for-service. And we also want to work with providers that are interested in transformation. And we get a lot of pushback and we hear a lot about this model, but we hear a lot of positive things too, of saying, we need more information, which we're not expecting people to sign on today, but we're very interested. It connotes and it does have all the features that we're talking about moving towards a population health based model. So simply put, under this model, we believe that hospitals will be able to further improve quality. They're already doing a lot of delivering a lot of high quality care, and become financially stable. So by improving quality, reducing some, and I understand some of these rural hospitals are very small in terms of admissions, but further reducing some of unplanned or some preventable admissions or hospitalizations or length of stay, improve operational efficiency, and optimize service profile. A lot of hospitals we talk about want to do telehealth or doing telehealth. They want to have kind of a wish list of things that they want to do, but they can't do under the current system. And we believe that that's not going to happen overnight. If this model is a multi-year model, but it will at least get rural hospitals on a different path to, again, to help make sure that that care is going to remain and is available in rural counties, in rural communities. This is what we've proposed in September of services that would be in the budget and what would be out in the budget. We haven't made any hard decisions after this, but again, this is up for, we appreciate any and all feedback on this. We've heard a lot about home health services. Why wouldn't that be included? And we're very open to including additional services. I will say, in full transparency, we came out with a model knowing that we didn't want to boil the ocean at day one, but this was September and things have changed, and we're happy to have more feedback and include and consider the things that are excluded in here. We've kind of put this out for reaction from providers and payers. A lot of things to still think about. That we've had a lot of discussions with the federal government, CMI, on employee PCPs, care transformation support. How would we support that? Glide path for hospitals joining the model. That specifically speaks to the RAP hospitals. Are there ways for, like Maryland have thought, is there a way for us to think about some considerations to make sure that those hospitals, whether they're really small or big, that they're set up to succeed under this model? And we are very open to those conversations. We're doing our own thinking on how that could work, and having conversations with the federal government with that as well. Again, as I already mentioned, that this would be voluntary for payers and rural health systems to participate. If we are able to secure agreement with the feds this year, we would be, in the next 6 months, we would be looking for letters of intent from providers in the fall. And they would, with a budget start date of January 2021. But the letters of commitment, those hospitals, rural health systems that are interested in participating would kind of start on this rural transformation, the care transformation journey in the fall or next year, to start figuring out how to set the budget and working with us, as well as setting up the care transformation plan approach before the budget goes live. This would be a multi-year project. We're thinking probably 5 to 8 years, and a phased approach in terms of hospitals. Our idea is that we would get 8 to 10 hospitals in the first year to participate, and then other years bring in additional hospitals that want to participate. On the payers, as I mentioned, voluntary phased approach starting with Medicaid and PEB and SEB, and that they would pay. I'm happy to talk more about the technical components of the model, but they would pay a prospective payment based on the percent of revenue to these hospitals now. This is just a quick slide to talk about the care transformation process, the care transformation plan process that we have envisioned, starting building off the community needs assessment reports that the hospitals are already preparing. In the proposed governance approach, this model is being led by the Healthcare Authority, but we would seek legislation to create a public-private board to regulate and oversee this model over time. And there's some models that we have that we've looked at so far. Again, here's the timeline I already talked about, and just nothing else on that. And then this is kind of built out of what the steps we've done since last summer, October, and what we see happening over the next 18 to 24 months. So I really whipped through that, and I apologize. But I'm happy to answer any questions, or if you want to contact me by email, that's also it's also available.
Is your contact information?
I'll
Right on here.
Our emails are on the last slide.
Oh, very good. Okay.
Except you email me and I'll pass it on through.
or you just change the first and last names, and you get the same.
Yeah, I certainly would encourage more interaction. But we do have a little padding built in before the board meeting itself starts. Are there any pressing questions that anyone really wants to put on the table right now?
I have a
Go ahead, Brooklyn.
and I work for local government, and so I don't exist in this world outside of my involvement. So a lot of what you said went today, but
I did talk fast.
Both of you. I feel like I'm a little more. And so sorry if the terms that I'm relating to this question are not how they were intended. But so you brought up involving employers in 2019 and 2020, and then also in one of your slides, understanding community needs, for example, leveraging things like the TNET. What is there an opportunity? Because I know I've had a couple conversations outside about how government or employers and employees can start supporting population health, because we do housing and transportation and education and employment, and that's a huge, we're focused right on a lot of that kind of reaction, but we're a huge part of the proactive approach. And so whether it's in this model or even currently with like the Medicaid work going on, is that employment and that kind of community provider and assessment involving non-clinical partners, or is that focused specifically on clinical partners?
No, it's involving non-clinical partners. So I'm trying to tease out. So when I said employers, we work, and JD, since he started the Healthcare Authority, the Healthcare Authority, as the largest purchaser, we are able to do a lot, but we have also wanted to spread and scale some of our work. So we work with other purchasers, local governments who are purchasing care for their employees and their members on different value-based purchasing strategies. So we work with them on those things. And then how I mentioned payers or employers on here is that some of the health plans that we've asked to participate in this model have self-insured health plans. And so they've said, if our employers say to do this, we can, but it's not our choice. So that's how I don't know if that kind of gets to your question, but that's why I point them out.
Okay.
Because they also have a very vested interest in terms of sustainability and transformation.
Yeah, and I know this is probably more of the private side, but And like we, through the Association of Washington Cities,
Yeah.
there's a huge effort around reducing healthcare costs on behalf of us as the employees and the employer. And I know it's a little bit different, but I think if we're able to expand that and start looking at how that approach works across the community in terms of those private partnerships, because if we have small businesses, that don't have leverage or aren't providing any type of care for their employees, and they're all using the Medicaid, and looking at that model like the Association of Washington Cities has, being able to kind of blanket over, a ton of the governments and also some private companies that are members of them, being able to support that kind of thing with like, hey, if I participate in a health questionnaire every year, I get $35 in a Visa card. Cool. I'm now Associated Washington Cities has 6 years worth of my health information that's self-reported.
Mm-hmm.
And so looking at that in terms of a broader population approach where we're bringing in those private partners, not necessarily private healthcare, but private economy, saying, hey, your individuals can participate in this way,
Mm-hmm.
or participate or be a part of this approach. I think the incentivizing can come in a lot sooner than just at the healthcare level. Just from my own experience with how we work at the city, and I don't know if that fits into this at all or that, but I think a lot of that community approach has to start happening before the clinical world. And I know that's outside of the demonstration focus, but I think in the long run, it'll impact the effects of the demonstration overall. So if it's possible, throw us in there.
Yeah.
Somewhere.
And I see Gail has a comment too, and we're going to need to break in just a minute.
A comment.
Yeah.
Through all of this,
Come to the mic, Gail. Yeah.
my comment is, through all of this, there was a lot of talk about essential health providers and safety net and providing financial stability. But if you look at it, none of this is applied to behavioral health providers. So there is no safety net for the funding of behavioral health providers like there is for the FQHCs. And what it sounds like is there's a lot of work around rural hospitals. So I think it's something to really keep in mind.
Okay. Well, I appreciate you coming all this way to be here in person. And certainly the topics you've helped us with are very important, and there'll be a lot more to say about them and listen to about them. Why don't we reconvene at 1:15 and have our briefest ever governing board meeting? And if there's nothing else burning for anybody, then we will adjourn for just a few minutes. And those who didn't want to stay for the board meeting don't have to. Except board members, of course. Yeah, sorry, Michelle.
Sorry.